Good morning, everyone. I'm Dr. Elizea Horne. As mentioned, I'm from South Africa, and I will be presenting the infant safety that was found on the IMPAACT 2009 study that we saw the exposures during intra-utero as well as through breastfeeding of oral daily PrEP as TDF and FTC. I just wanted to say I'm presenting this on behalf of the author, which was Linda Stranix-Shabanda. She wasn't able to make it today. Next slide. Oh, this. Oh, very good. Thank you. Okay, just to mention that we didn't have any conflicts of interest. So just to give everyone a little bit of background, we all know that daily oral PrEP as tenofovir disulfurate as well as emitricitabine is an important component of HIV prevention, not just in South Africa, but generally in pregnant and postpartum women. Our safety data, as well as our pregnancy data for the maternal participants, has been presented at COI 2024 by one of our protocol chairs, Ben Chai, and it has not raised any concerns. We also have reassuring data showing safety of TDF exposure in infants, intra-utero, and through breastfeeding as well. The study aimed and investigated the adherence, the pharmacokinetics, as well as the safety of daily oral PrEP in pregnancy and postpartum. We also all know that TDF exposure in infants can cause some safety concerns with regards to growth, kidney function, as well as some bone formation. So in this study, we evaluated and compared the incidence of infants' adverse events following intrauterine exposure to oral daily PrEP versus the PrEP exposed as well as the PrEP unexposed newborns. The study design. IMPAACT 2009, we enrolled pregnant HIV-negative women below the age of 32 weeks gestational age, between 16 and 24 years of age, in 4 African countries: Zimbabwe, Uganda, Malawi, and South Africa. Participants opted to either initiate PrEP, which would be defined as cohort 1, or decline PrEP, which would be defined as cohort 2. But they also had the option to switch throughout their pregnancy and postpartum, which we would call them cohort 2, step 2. For the infants, they were followed up at week 6, 14, and 26 weeks. Our infant adverse events were assessed for any grade 3 or higher, or infant deaths, through the 26 weeks of follow-up, and it was assessed using the DAGE grading table July 2017 version 2.1. Some of the outcomes that we were looking at was the bone mineral contents via DEXA scans, which was assessed in a different facility, creatinine clearance by your modified Schwartz criteria, as well as the length for HG scores at birth and at week 26. Exposure was defined as any maternal participant that started oral PrEP during pregnancy and prior to birth. So the statistical analysis is we identified and tried to do the incidence rate of the infants' AEs among the PrEP exposed and the PrEP unexposed, and that was calculated. The unadjusted incident rate ratio of the cumulative adverse events up to the age of 26 weeks among the PrEP exposed and PrEP unexposed infants was estimated based on the POISE distribution with a 95-fold confidence interval. The difference in mean infant growth as well as development outcomes were assessed at birth as well as week 26 of age among the PrEP exposed and PrEP unexposed infants. And we used the 2-sample t-test at each time point. Looking at some infant demographics. So just to make this clear, we enrolled 350 participants in the study, which accounted for 229 in cohort 1 and then 121 in cohort 2. However, only 329 pregnancies delivered as a result. So we are looking at 329 live births in this study, of which 230 were PrEP exposed and 99 were PrEP unexposed. The group 1, as you can see in the table, had a higher proportion of males and mean birth weight. Otherwise, the birth characteristics seems quite similar. I just want to allude you to the table. As you can see, cohort 1 in here is 217. Cohort 2 is 112. In the 112 cohort 2 participants, 13 of these moms actually opted to switch PrEP, so would become a cohort 2 step 2 participants. Antenatally, 4 of them switched, and postnatally, 9 of them switched. Looking at infant adverse events, if we look at grade 3 and higher incidence ratios for the PrEP exposed participants, we had 66.3 per 100 person years with a 95% confidence interval of 45.8 to 95.9. In the PrEP unexposed, we had 51.7 per 100 person years and 95 confidence interval of 28.4 to 94.1. The incident ratio we are looking at is 1.28 with a 95% confidence interval of 0.63 to 2.59. Most frequent reported AEs was common amongst our settings, which was nutritional disorders like underweight, infections, respiratory conditions, and perinatal conditions. No AEs were assumed to be assessed to PrEP. We, however, did have deaths among the population groups. We had 9 deaths among the PrEP exposure, and we had 5 deaths among the non-exposed infants, and the deaths were deemed to be not PrEP-related. One question that might come up, why was there more deaths in the PrEP exposed? So it was mostly population-related deaths that occur. Prematurity as well as sepsis were the most common causes of death. If we look at the other characteristics or outcomes that we were looking at is bone mineral content in the infants. We were looking at growth using the length for age Z-scores, and we were looking at creatinine clearance. If we look at the table, we can clearly see that there wasn't a lot of difference between the creatinine clearance as well as the lumbar spines at week 26. So just to clarify, infants only had a full body scan at birth and a lumbar spine, and at week 26, only a lumbar spine. So for that reason, we're only comparing the lumbar spine. And then the creatinine clearance, as you can see, was also not a lot different. However, for the length for age Z-score, based on our p-value, you can see we trended towards a lower length for age Z-score among the PrEP-exposed participants. In conclusion, adverse events were definitely more frequently reported amongst our PrEP-exposed participants. Question, why? We also need to account for the fact that this was not a randomized trial, and the choices that's made by moms in terms of whether they choose to be on PrEP or not be on PrEP can obviously affect the influence of the infant outcomes in terms of health. We also need to look at some of the factors that we can see, some of the birth characteristics in terms of the birth weight, as well as the other outcomes being more common, but this is very population specific and is very common amongst the populations assessed in the 4 African countries that was mentioned. Overall, the infant data is very reassuring for this rigorous clinical trial, and daily oral PrEP remains very safe and an important option for HIV prevention during pregnancy and postpartum, especially for those that assess themselves as high risk. I just wanted to say a big thank you and acknowledge our protocol team, our funders, IMPAACT Network, all of the sites from Malawi, Zimbabwe, Uganda, and South Africa, all of our wonderful study participants for partaking in this study, our protocol chair, Benchi and Linda Stranix-Chibanda, as well as the study products which were provided by Gilead Science. I'm open to any questions.